Welcome, everybody, to the PT on Ice Daily Show. My name is Eric Chaconis, and I teach the extremity management course for us, as well as the primary care physical therapy course alongside Morgan Denny. Morgan is a wealth of knowledge. It's been a lot of fun to teach that course with her, and we just finished our first cohort, actually, this past Sunday night. And we had a great group. The group of learners that signed up for that first cohort and engaged with us, and now we're getting to go through their final projects this week and look at what they created from the learning experiences that they had in that course. We're really lucky to have such a great group. And so we're launching it again. We're going to do our second cohort in June, coming up June 7th. You can sign up for that on our website, ptonice.com. And I want to give you today a little bit of an excerpt from the integumentary system content from what we cover in that unit. And so we have kind of a systems-based approach. We're going to cover cardiovascular pathology, pulmonary pathology, gastrointestinal, urogenital, hematology. We go through all the systems, and then we also specifically go into certain regions. So we look at ears and eyes. We look at diabetes, specifically looking at not just endocrine pathology in general, but really a deep dive into diabetes, high blood pressure, all sorts of stuff. What I want to talk today is a little bit about one of the most sinister of all skin conditions, which is melanoma. And it's critically important that we as physical therapists are able to look and really screen for melanoma in some ways as a member of the healthcare team. So when a patient has not had a skin check by their physician, they haven't had their annual skin check by their primary care doc or their dermatologist, that's really where we come in. And it's that person that fell through the cracks, they didn't go and get their skin check, or they're between skin checks, and you happen to notice a mole that you believe needs medical attention. That's really what we're talking about here. We aren't evaluating moles the way that a physician evaluates moles. We aren't screening for moles the way that a physician screens for moles. We are doing it in the context of in musculoskeletal care and outpatient practice. When we see something, we say something. And so the more knowledge you have, the more you're able to accurately see things that potentially could be sinister. And so melanoma is a big one. Worldwide prevalence of melanoma is fairly significant, and it's up to us to have a strong working knowledge of how to screen for it. So what happens is pretty much out of control melanocyte growth, right? You end up having growth that occurs both in a radial direction and can get into the capillary beds, into the subcutaneous tissue, as well as radial growth, so radial and vertical growth. But the scenario is that, I've got my patient, I've been seeing my patient for a couple weeks now, and I have him take his shirt off, and I notice on his back a mole that potentially is abnormal and potentially needs medical evaluation. In the context that he hasn't had that mole already evaluated by his provider, then that's where we come in to potentially make a referral. You can see the lifetime risk there is still relatively low, but the survival rate is exponentially better the sooner it is caught, right? And so that's the case for all cancers. But if we're able to catch melanoma in the initial stages, you can see a 97% 5-year survival rate, which is tremendously better than in the later stages. When we start to see things progress is when we start to see a much worse prognosis. There are a number of risk factors to melanoma. Obviously, we look at the skin color complexion of the individual, and certainly Caucasian individuals are more at risk than people that have more melanin in their skin, darker complected individuals. But ultimately, it comes down to UV light, sun exposure, although you'll see some conflicting evidence of that as of late. You still see melanoma in areas that do not get much sun exposure. So an area that for an individual that is most commonly covered up, you wouldn't expect them to get melanoma in that region of the body. That actually does occur. So It's not just sun exposure. But the important thing to take away is there is no such thing as healthy sun exposure, a healthy tan. That doesn't exist. Sun exposure can be damaging, and it's dose dependent, right? So not only the intensity of the sun, the time of day that you're exposed, but the duration and how long you're exposed, and the age at which that exposure occurs. The younger an individual is when they have sun exposure, usually the more negative impact that can have later on in life. Tanning beds are notoriously bad as far as obviously being a risk factor for melanoma and sun exposure, especially tanning bed use at an earlier age of life, right? That's where we worry more. So it's cumulative. The exposure is cumulative over time. And when you have a lot of these very severe sunburns at a young age, and they add up over time, over the course of life, then that's when we can see higher risk of melanoma. Other things to think about: a weakened immune system. Certainly that makes people more at risk. Those that are on immunosuppressive medications or have co-occurring other medical conditions that weaken their immune system, that will be something we would want to consider. And then certainly a history of cancer, history of skin cancer in your family, history of cancer of any kind in the individual makes them at higher risk, and we would be more quick to make a referral, right? When we see something when those risk factors add up, we'd be more quick to make a referral. So a normal mole is called a nevus. It should be round or close to round. It should have a nice, even, smooth border, right? It looks pretty normal, and it's a shade of brown or tan. It's not multiple colors. It's a single color, and it doesn't change. So over time, that mole is stable. And typically what we look for is a small mole. It is about a quarter-inch diameter in size. The size of a pencil eraser is about what you want to see as far as the diameter of it. So we teach the ABCDEs of melanoma screening, which are very standard. This should be taught in every single PT school. And as PTs, we just got to keep up and remind ourselves of the ABCDEs. So A is for asymmetry, which if you were to draw a line right down the middle of that mole, it would be the same on both sides. So it is a symmetrical mole. There is no difference right versus left. You can see here on the right, this is an asymmetrical mole in its shape. It's elevated on one side, and the shape of it is asymmetrical. If I were to draw a line down the middle, it's not going to look the same on both sides. So an asymmetrical mole is a bit of a red flag. Looking at border, we do not want to see any irregularities to the border. So these scalloped or notched edges of the border, these would be another red flag. That would be positive for border. We do not want to see that, right? We want to see a nice, smooth, regular border. Sometimes you see these fuzzy, kind of blurred regions at the border, and that would be another thing that would be positive for border. Color, it should be one shade. It should be a single shade. It should not be more than one shade. So two different colors of brown, two different shades of brown here would be positive for color. So if you see two or more colors, then check the box for C color and make that referral. Also recognizing sometimes that there are all sorts of abnormal colored moles. You can see different shades and patches of red or a bluish tint, a pinkish color, and those would be all positive for color. Diameter and evolving, probably one of the most important of the different metrics when we look at the ABCDEs. This is the one that has the strongest positive likelihood ratio. If the mole is growing, if it's evolving over time, then that would be positive. That's per patient report, and that would be positive for evolution or evolving. And so, if it's a large mole, then obviously that's the diameter is exceeding the size of a pencil eraser head, then that would be positive for diameter. But you have to ask them, have you noticed this mole growing or changing over the past several weeks to several months? That would be positive for evolving. So you can see here all the different likelihood ratios for melanoma, the different test results. If we were to have a positive enlargement, then that has a positive likelihood ratio for 8.4. You can see the others are relatively low as far as positive likelihood ratios go. So really what you want to do is cluster this, just like anything else. You want to cluster your findings. And so we see with the increasing number of findings increases the need for referral, increases the likelihood that in fact the mole is in fact sinister and would require referral. But in our context and what we're doing, we're not evaluating the mole in the context of should I biopsy it or not. We're evaluating the mole as should I get this person in the hands of a medical provider, dermatologist, or primary care who can evaluate it from a medical standpoint and biopsy it. Ultimately, the mole has to be biopsied. And so we don't necessarily need to have 3 or 4 findings to make a referral. We could have one finding. We could say, you know what, that mole is positive for border only, nothing else. But because you haven't seen your provider in the past year or 2 years or 3 years, you've never gotten a skin check from a dermatologist, I think you should go and get seen based on that variable alone, right? So we don't need to have a large cluster of findings to make a referral. This just helps you understand in the context of the literature when they look at, to biopsy or not to biopsy. There are a number of other warning signs to look out for. Obviously, this is per patient report. If they feel like there's pain in that region of the mole, if it's itching, if it's crusting or swelling or bleeding or oozing, anything like that is a red flag, certainly going to warrant referral. And then important to note too, nodular melanoma is one of the most dangerous forms of melanoma because of its really aggressive vertical growth. So nodular melanoma, it's going to grow down into that capillary bed, and so that can be much worse from a prognostic standpoint as far as the aggressive form of melanoma. We see this more so in men, more so in older men than women, but be aware of that. There are more aggressive forms of melanoma. Nodular would be a good example. So what do you do? What are the next steps? Well, certainly we are referring. We are not diagnosing. We are not biopsying these atypical moles, but we are referring. And so we want to ask the patient, have you seen another provider? If you haven't, then we'll make the referral just simply based on that. A good relationship between a physical therapist and a dermatologist, that's not somebody you always think of in the realm of physical therapy, another provider that you'll share patients with and make referrals, but you should. You should. A dermatologist is an excellent person to get to know, to make referrals, because you're going to see all sorts of funky skin lesions and stuff like that that you want to send off to a dermatologist or a PCP, and that's really important. The other thing is dermatologists see a lot of rheumatic conditions that are seen by physical therapists. So that's a nice relationship to have, in that if the dermatologist is managing a patient with psoriatic arthritis or something like that, to know that you're there and that you're a provider in town is helpful for them as well. All right, so we refer when we see a new onset of skin lesions in children, medically evaluated right away. There's no real questions asked there. Any skin lesion or open sore that has not healed in the past 4 weeks, that needs medical evaluation, certainly. And if we see a new skin rash or lesion when a patient has a history of malignancy, that's a referral. That's an easy referral. So these are all in addition to just the same old positive ABCDEs. We make a referral for that. So a little snippet on melanoma screening for you. Hope that helps, and have a great day, everybody.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.